Hi everyone, I'm Dr. Vikas, emergency consultant from Manipal Hospital, Lanka. So today I'll be discussing about atropine and pralidoxime. So as all of you know that atropine and PAM are the first line antidotes for OP compound poisonings. So it is common poison, especially in India and South Asia. So what OP compounds does it? It blocks acetylcholinesterase, causing increase in acetylcholine, which in turn causes cholinergic crisis in the form of muscarinic, nicotinic, and CNS effects. So the treatment will be rapid atropinization and pralidoxime, which improves the outcome. So coming to pharmacokinetics, OP are highly lipid-soluble compounds and are well absorbed from intact skin, oral mucous membrane, conjunctiva, and the GI and respiratory tracts. So they are rapidly redistributed to all body tissues. The high lipid solubility means that they easily cross the blood-brain barrier and therefore causes the potential effects of the CNS. So metabolism occurs principally by oxidation in the liver, and elimination is mainly via urine, bile, and feces. So coming to mechanism of action, what you see here is, acetylcholine released from the presynaptic neuron binds to the receptors on the postsynaptic cell and causes normal signal transmission. So here what happens is acetylcholinesterase in the synaptic cleft rapidly breaks down acetylcholine, stopping the signal. So OP compound, what it does is it inhibits the acetylcholinesterase. So acetylcholine accumulates and overstimulates receptors, producing cholinergic excess symptoms. So coming to the clinical effects, it is again because of the cholinergic excess in the form of muscarinic, nicotinic, and CNS effects. So the muscarinic effects of cholinesterase inhibition can be remembered by mnemonic sludge tumbles and killer bees, salivation, lacrimation, urinary incontinence, defecation, GI pain, emesis, meiosis, and the more severe form of effects, which are bradycardia, bronchoria, and bronchospasm, which are called killer bees. So the nicotinic effect of cholinesterase inhibition are muscle fasciculation, cramps and weakness, metiasis, pallor, and also tachycardia, hypertension. The CNS effects of cholinesterase inhibition are anxiety, restlessness, tremors, headache, confusion, and in severe cases, it is seizures and coma. So coming to management of OP compound poisoning, usually first thing what we do is decontamination. Protective clothing must be weighed to prevent secondary poisoning of healthcare workers, and monitoring, cardiac monitoring, pulse oximeter, and 100% oxygen has to be given. Coming to gastric lavage, there's no proven benefit. If a patient comes within 1 to 2 hours and has consumed large quantities, we consider giving gastric lavage. So it is not, and also the adverse effects are aspiration can happen in an unconscious or drowsy patient. So the antidote for OP compound poisoning is atropine. So the initial bolus dose is 2 to 3 mg IV. Double the dose of IV atropine every 5 minutes to achieve adequate atropinization. So what you look at is clear chest auscultation, heart rate more than 80, and systolic BP more than 80. Then comes your continuous infusion, that is 10% to 20% per hour of initial dose of atropine that was required to achieve adequate atropinization. So next is pralidoxime. It should be given as soon as possible and can be given up to 24 to 48 hours after exposure, but should be given as early as possible to prevent aging. So the dose is 30 mg per kg, followed by continuous infusion of 8 mg per kg. So if the patient has seizures, benzodiazepines will be given. So coming to atropine, it's a belladonna alkaloid, competitive muscarinic antagonist. It blocks acetylcholine at M1, M2, and M3 receptors. Does not act on nicotinic receptors, no effect on muscle weakness. So the mechanism of action, again, it is competitive antagonism at muscarinic receptors. The effect on M1 reduces the CNS cholinergic symptoms, M2 increases the heart rate, and M3 drives secretion, decreases bronchoria and bronchodilation. So the clinical effects of atropine are reduced respiratory tract secretions, and it reverses bronchoria, improves airway patency, and do not reverse muscle weakness. Tachycardia is not a contraindication. So basically, atropine is primarily used in OP compound poisonings, carbamate poisonings, and nerve agent exposures. So other few indications for using atropine is symptomatic bradycardia, pre-anesthetic medication, AV node tox, bronchoscopy pre-medications, and muscarine type mushroom poisonings. So dose, as discussed earlier, initial dose will be 2 to 3 mg IV. So titrate by doubling every 5 minutes until atopenization is done. That can be confirmed on chest clear during auscultation, heart rate being more than 80 and systolic BP more than 90. See, massive OP injections will require a huge quantity of atropine. So infusion 10 to 20% of total atropine used for atopenization per hour. So the goals of atopenization therapeutic endpoints are, as discussed earlier, dry lung fields, no V's, heart rate more than 80, systolic BP more than 90, and dry mucous membrane. So pupillary dentation is never reliable and shouldn't be used for endpoint of atopenization. So the contraindications for atropine, none absolute, but relative contraindications is MI and tachyarrhythmias. So again, as discussed earlier, limitations are does not reverse neuromuscular weakness, may cause anticholinergic delirium, and usually large doses are required in OP poisoning. So the side effects of atropine are hyperthermia, tachycardia, flush skin, urine retention, decreased sweating, delirium, and hallucinations, and absent bowel sounds. So coming to pralidoxime, it's an oxime antidote. It reacts with acetylcholinesterase and it reverses the muscarinic, nicotinic, and CNS symptoms. So coming to mechanism of action, pralidoxime reactivates acetylcholinesterase that has been phosphorylated by OP compound by binding to an anionic site and cleaving the phosphate enzyme bond, thereby restoring breakdown of excess acetylcholine and improving neuromuscular function. So clinical points, pralidoxime has to be given as early as possible and more effective in acute than chronic OP poisonings. WHO recommended dose is 30 mg per kg IV bolus, then followed by an infusion of 8 mg per kg per hour. So it has to be continued until acetylcholinesterase levels improve. So again, indications for pralidoxime are OP poisoning, nerve agent exposures, cholinesterase inhibitor overdose. So other uses for pralidoxime are myasthenic crisis due to overdose of peridostigmine. So drug-induced cholinergic crisis and some paralytic shellfish poisoning cases, pralidoxime is used. So the contraindications are hypersensitivity and also myasthenia gravis, may worsen weakness. Limitations are asymptomatic patients, known carbamate exposure with minimal symptoms. Evidence of mortality benefit in acute OP poisoning is inadequate. So side effects again, tachycardia, hypertension, muscle rigidity, nausea, vomiting, diplopia, blurred vision. Thank you.